Good evening, everyone. It's a great pleasure in welcoming you all for the IPNA endorsed Webmaster Series 2020. It's spanning till December 23rd. Today, we have three eminent speakers for the day, Dr. Akash Deep, Dr. Anil Vasudevan, and Dr. Sasidaran. The first talk is on AKI in PICU, Prevention and Conservative Management by Dr. Sasidaran. Dr. Sasidaran is a consultant intensivist and head of PICU at Mehta Multispecialty Hospital, Chennai. His area of interest is acute care nephrology, non-invasive ventilation, stem cell therapeutics, immunity and infection, immunotherapeutics, and he is a recipient of several grants, and he is a recipient of IPNA, WFPICCS, Sepsis Society Travel Grant, BMGF, and IPA. He has got a research grant for DBT, and he has contributed several chapters in pediatric critical care and nephrology. He is a reviewer of Indian Journal of Critical Care Medicine. He is a program director of DNB Pediatric Critical Care. He is the director of VS Institute of Hemato-Oncology and Stem Cell Transplantation. He is a clinical advisory board for HTIC, Indian Institute of Technology, IIT Chennai, and he is an NABH assessor for Hospital and Ethics Committee. Over to Dr. Sasidaran.
Yeah. So, thanks to Dr. Kalaivani for giving us such a nice platform to discuss all about AKI today with the three series of lectures. I will begin with AKI and PICU. Prevention and conservative management. So when we discuss about AKI in PICU prevention and conservative management, first step is we have to understand what is the definition and application of AKI in PICU. So this is the spectrum of disease development over timeline in kidney injury. So first there is a normal kidney, and then there is an increased risk and damage state, and then it goes to the reduced GFR state and kidney failure. It may progress to acute kidney disease, and this can further progress to CKD, and the end result may be death or with disability. So when we say that this is the spectrum of progression from the damage to reduction in GFR to kidney failure, what happens to the GFR is GFR starts coming down from the state of damage to state of kidney failure, and at the same time the injury is going to increase. So when you see this may be the 100% normal GFR state, and it reduces near about 50% to be identified by the creatinine measure. This is what we conventionally understand. So there is a stage that is the damage stage where the measurement becomes difficult to identify early stage of kidney injury. So a reduction in GFR maybe beyond 50% depicted by the creatinine and kidney failure constitutes something called acute kidney injury. And there is something more to it, that is a subclinical AKI, that is the subclinical kidney injury, which may not be easily identified. And there are many biomarkers at this state which may help, like IPNA and TIM3. So these biomarkers may help us to identify, but these biomarkers are currently evaluated predominantly in cardiac and post-surgical situations. And there is another important and interesting thing. Till the kidney failure state, if we institute proper measures, it is a reversible kind of an injury. So we can revert it even to normal or to any stage of betterment. So this is very, very important to understand. So if the reversal doesn't happen and therapeutic measures are quite delayed, what happens eventually is the patient may progress to acute kidney disease, and as I already told, it may further progress and end result in even death or some amount of disability or residual renal dysfunction. So the injury can be reduced, so the pathway is reversible. That's what we need to understand as an intensivist and as well as a nephrologist. So AKI staging there were like evolution of development from the rifle staging in adult and P-rifle and akin criteria. Currently, based on 2012 KDIGO guidelines, we try to classify kidney dysfunction in ICU. And this is based on serum creatinine criteria and urine output criteria. Serum creatinine 1.5 to 1.9 times the baseline, 2 to 2.9 times the baseline, or more than 3 times the baseline. On the other side, there is less than 0.5 ml urine output for 6 to 12 hours, more than 12 hours, and more than 24 hours. The good thing about this is this KDIGO guideline is applicable even in patients less than 18 years old. So this is a common platform, common classification system can be used. And this is very, very important. And this is a universal classification system can be adopted. And there is an important another metric in kidney injury determination, because we know that there is something called CKD. So we have to decide what is AKI and what is AKD and what is CKD. So AKI is usually by timeline 0 to 7 days process from the beginning and manifestation. Transient AKI, we will say 0 to 48 hours, because when the AKI start regressing, that means the kidney status start improving less than 72 hours, the improvement and the residual dysfunction like residual dysfunction will not be much, and the improvement may be more favorable. So persistent, instead of putting 72 hours on the safer side for the definition, they took 0 to 48 hours. So more than 49 hours up to 7 days, we always need to think about the possibility of residual renal dysfunction. And when it goes to beyond 7 days up to 90 days, we can classify that as acute kidney disease. And there are like some proposals to classify acute kidney disease also to multiple subclasses, but it is not currently under recommendation. So AKD includes AKI as well. So if AKD is not resolving and it is going to persist beyond 90 days, you may be calling it as CKD. This is a very important point. When we understand the AKI guidelines or definitions, we have to apply it in ICU. ICU patient population have a different characteristics. So there are few things we have to keep it under, we have to be mindful while we are applying this in ICU. Different age groups, neonate, children, young adults, and elderly, there may be some intricate differences. They may be with or without comorbidity, with or without pre-existing renal disease. And another thing is by AKI episode, it may be the first episode or it may be beyond first episode. They may be receiving some pharmacological agents like diuretics modifying the urine output. In adult, they may be receiving before hospital admission as well. Fluid status in the index patient, the FO percentage we need to be carefully seeing at, and acid base and electrolyte disturbances may be coexisting. So all this have to be taken into consideration to classify a patient with AKI in ICU. So when we go back to the AKI criteria, so there are some limitations. So one is, I have already told in the previous slide, there is a patient characteristics based differentiation that has to be done in addition to this. There is another thing which is called UKI. There are some intrinsic limitations in the definition itself. So when we see this serum creatinine based criteria, we always say it's baseline creatinine. What is baseline creatinine is a little bit of a confusion. Similar limitation exists in urine output also. For practical purposes, baseline creatinine, what we can take is most recent outpatient serum creatinine, if it is available and estimated in 7 to 180 days in the past. In pediatric cases, we can take creatinine, creatinine we can calculate by the secret creatinine based formula or the modified Schwartz formula, where if you input a factor of 1 to 0 for glomerular filtration rate, you can calculate the creatinine. It may be the indirect measure. We can't say that it's too good and too right. But when you are not having a outpatient most recent serum creatinine, instead of taking first inpatient serum creatinine, this may be like preferred by most people. And So when you go to the urine output, so urine output also, we say simply 0.5 ml, and this is the time 12 hours, more than 12 hours, and more than 24 hours. If you go to real application, real life application, if we take a scenario of adult weighing 90 kg, urine output of 40 ml per hour for 18 hours, the creatinine showing no rise. As per KDGO, your expected urine output is 45 ml per hour. And this patient has a potential to mount almost like 960 ml of urine in 24 hours if he is going to maintain this amount of urine output. For any adult intensivist, they say that near about 1000 with no creatinine rise, they don't even think about AKI. But according to the classification system, it may be AKI stage 2. So the another thing is pediatric, does it have any limitation? Yes, a 14-year-old boy weighing 65 kg, urine output is 20 ml per hour for 6 hours, started on furosemide stress test and started having 100 ml per hour for first 5 hours. This is a routine thing we see in ICU. There is a transient response to furosemide stress. And then subsequently, it is again coming down, the decremental of 40, 30, and 20. So now, if you want to classify the stage, whether you have to take the 6 hours plus 5 hours plus this 2 hours of this thing that is 6 plus 8, 2 plus 5, that is almost like 15 hours, or how 13 hours, or how you are going to take to stage it. So whether you are going to take this 3 hours alone and you are going to stage it. So the staging also may be a problem based on these criteria. So there are limitation exist. Urine output in obese patients, there is a non-linear relationship with weight, so strictly going based on the numbers may not be possible. Urine output criteria is most sensitive in pediatric population, may not be so in adult population. And urine output based AKI and serum creatinine based AKI stage are not calibrated to each other, because the stage 1 by 1 may be stage 2 by other. Urine output is a physiological variable and it can be manipulated by the pharmacological intervention, like very well known diuretic measures. And serum creatinine rise of 0.3 milligram per deciliter from baseline in CKD patient may be inconsequential. So they may not be therapeutically informative, but may be classified as AKI. And there is no standard measure to denote subclinical AKI and hemodynamic AKI. These are all the limitations. Though there are limitations about the patient characteristics and the urine output criteria and the creatinine-based criteria, and poor calibration among these three criteria among themselves. So we are very comfortable in using this KDGO definition, because that this is as of now, like, and up till now, it is the most well calibrated and really clinically very much useful methodology. And then now we go to the initial step. Is I've just given a background to understand what is acute kidney injury, how we understand acute kidney injury based on definition, and how we apply that in hospitalized patient, especially in a patient admitted in ICU with the limitation. Now we directly go to prevention and conservative management. This is the core topic. And prevention approach in AKI, maybe this is the most important slide. There is a preventive approach in AKI management, which include all these following steps: optimizing circulatory volume, optimizing the mean arterial pressure to restore the renal perfusion pressure, vasoactives if needed, optimize the oxygen carrying capacity, correct the hemoglobin based on your ICU's trigger values, monitor and maintain electrolyte homeostasis, which is very, very important. Hyperchloremia cannot be negated, because there is very significant data currently saying that any kind of hyperchloremic acidosis may be associated with worsening AKI. Avoid all non-essential nephrotoxins. If possible, you remove. If possible, otherwise you avoid non-essential nephrotoxins like contrast medication, especially iodinized contrast. Perform appropriate therapeutic monitoring or dose adjustment for all antibiotics. Consider context-specific interventions like steroid in specific situations, IV immunoglobulin in specific situations, total plasma exchange in specific situations based on the primary diagnosis. Along with monitor and avoid excess fluid accumulation, and this is a very detrimental factor, especially for AKI, as well for organ crosstalk-induced injury in AKI. So with this, we will discuss based on the available time, 2 case scenarios, and this is kind of a case summaries to understand how to apply all these things in a clinical setting. So this is a 8-year-old male child with fever and cough for 5 days duration, with fast breathing of 36 hours. And this child, you can clearly say it is a community-acquired lung infection. And this child was admitted, started on oxygen and respiratory distress was there. The child has been empirically started on piperacillin tazobactam plus vancomycin. This child has received 3 days of piperacillin tazobactam before reaching the current setup. So now what happens further is chest X-ray was showing a left lung consolidation, leukocytosis, CRP is 149. It's quite significant. It's much above 6, which is our cutoff value. Urging chest is moderate pleural effusion. Pleural fluid analysis showing a 3.8 gram protein and 13,000 leukocyte count, predominantly poly says that it's class 2 of lights empyema already. And pleural fluid to serum protein ratio is 0.6 and LDH ratio is 2.6. Everything contributes to say that it is probably empyema. And here, what we are going to do further is the child has been managed with antibiotic, and clinically the child was quite improving. The respiratory distress is coming down on day 7, afebrile, respiratory distress is improving, not requiring much intervention. CRP in the reducing trend, it came to 46, having vomiting 2 to 3 episodes per day for last 2 days. This is a little bit worrying. And urine output was remaining good. So because the vomiting episode, the creatinine has been repeated. To the surprise, we got a creatinine value of 2.25 milligrams per deciliter. The baseline was 0.4 on day 1. So here we have a very clear case of community-acquired infection, which is a complicated pneumonia, where the empyema is significant. The basic clinical condition is quite improving, and we had a surprising creatinine level on day 7. So on day 7, this is the creatinine 2.3. This child is conservatively managed with the elimination of nephrotoxic medication. Vanco stopped and linezolid was added. The Vanco, people may think that we can, when Vanco has been started, we have to send the drug level. The trough level has to be sent before the 4th dose, and that has to be monitored, kept under 20 value. Those things are absolutely right. We understand that vancomycin drug level vary based on volume of distribution, which is quite common in complicated pneumonia. Unfortunately, in our unit and most of our places, vancomycin trough level estimation is not that easily available. Even we get the report after 2 weeks or 1 week. That's why it is not very commonly done. So this is the brunt of injury we got for that. So subsequently, with the conservative management stopping vancomycin, it has come down. And this is kind of like urea coming down trend and resolving AKI, clinically improved and discharged home. But what you need to see is the child clinically improved on day 7 itself. Though the child came out of ICU, stayed in ward till day 15. So obviously there is an associated economic burden also. So when we approach AKI, we will just go into the simple platform, and there are different causes of AKI. So in this child, we can directly say that this AKI due to drugs. And so drug-induced AKI is a very interesting topic because it is completely preventable most of the time. So it may be because of the glomerular insult, tubular insult, or a tubular interstitial insult, and it is not less common. At least in pediatrics, it is 16% of hospitalized AKI patients. So common nephrotoxic medications, either by hemodynamic changes or by acute tubular injury or by acute interstitial nephritis or by intratubular precipitation or by osmotic nephrosis, they can cause AKI. The list is lengthy and it is ever-growing list, so I'm not going into the list of medication, but if you go into this list, you may be able to understand there are many, many more very commonly used medications in this list. So understanding this in Cincinnati children, starting from Cincinnati children, then in multiple centers in US, they introduced this kind of nephrotoxic injury negated by just-in-time action. This is a quality improvement tool, and it has many publications, almost like 5 publications up till now. And all non-critically ill children admitted in 9 hospitals were enrolled, and they created a very good, nice 57 drug list based on evidence and review meetings. And they used this to monitor the exposure, and the exposure-based AKI they calculated, and they created a very good outcome impact, that is nephrotoxic medication associated AKI rate reduction by 23.8% by Ninja implementation. I'm not going into the this improvement tool and how the study has been done, all this, but this is very, very important to know. 23.8%, that is 242 episodes are avoided in 1 year, 12 months time period, is not at all simple. And this is very, very important to understand. And what we can do to prevent nephrotoxic medication associated AKI: keep the child euvolemic, avoid aminoglycosides, avoid Vanco if no drug level monitoring is available, check the drug-drug interactions, and perioperative renal risk assessment. And sometimes we can use a simple risk screening like this one, based on age group, whether the patient is having sepsis, renal functional reserve, likely normal or likely abnormal based on his previous disease state, what is the number of nephrotoxic medication, what is the number of organ involvement, and current vasoactive medication need, post-operative or trauma state, burn injury, post-transplant, where the risk of AKI is more, and volume depletion, radio contrast exposure. These parameters, this is like, it is a very simple tool, and this is not validated anywhere, which we commonly use. But the similar kind of tool you can create as a quality tool for your own unit. And this need not be like similar to this, but it is up to your comfort. So in this case summary, we highlighted this remove or avoid all non-essential nephrotoxin, therapeutic drug monitoring of antibiotic, how much it's important, and avoid excess fluid accumulation is also how much it's important. And now the next case story goes like, a 5-year-old male child, fever and cough of 2 days, altered sensorium of 1 day, and GCS was low. The child has stridulous breathing, neck stiffness, and positive Kernig strain. So this child requires many resuscitative measures. This is what is different from the other child we discussed. This child was intubated, anti-rise DICP measures have been started. MRI brain and contrast have been done on day 3. That was normal. Child has initially started treatment like autoimmune encephalitis. IVIG was given. In the beginning itself, ceftriaxone, IV acyclovir, and artesunate was given. Later, artesunate was stopped because the MP smear was negative. H1N1 came positive. This child finally diagnosed to have H1N1 meningoencephalitis. This is the creatinine trend in this child. If you go through, there is an increase. And what are all the interventions we have done is, beginning we have given a 0.97 bolus of 2 doses 10 ml per kg, and the child had received multiple medication, 3% saline, mannitol, acyclovir, IVIG, and the child had received the MRI contrast, oseltamivir. And day 3, the creatinine was maxed to 1.4, and the child remained hypertensive for 48 hours, no fluid overload, good urine output. This is a favorable trajectory. So we have been just monitoring the child, but the good thing is over next 48 hours, the child started showing an improvement trend. So if we fix this as a AKI cost diagram in this, we have drugs as well. We have a very big background of H1N1 encephalitis with multiple organ involvement, with the intubation need and other things. So we can say very clearly that it's a very tough situation. It's not a very simple situation, and it is most of the time in ICU, the cost may be more than 1. That's classic in this child as well. So I'm already we told that this electrolytes, we have to be very careful. When you see the electrolyte trends, almost simultaneously you can see the sodium rise. Partially we want sodium around 145 to 155 or 150 in raised ICP cases because it's very favorable for ICP. It's part of the ICP management protocol. But at the same time, the high sodium may not be very much okay for a vulnerable kidney. So we have to balance it, and most of the time we have to be very mindful about what are all the saline containing medications we are giving. In this child, we have given 3% saline bolus as well, infusion for ICP management. Saline maintenance we have been giving, and the child had received the saline bolus in the beginning, and other nephrotoxic medications are additional injury. So over the time, what we understood is there is an excellent paper by Dr. Kellum et al. Which clearly describes the physiological basis for the fear in the so-called normal saline, but it is an abnormal saline. Comparing to plasma, when you see 0.9% saline, the sodium is high, chloride is high, albumin, there are many physiological variations, so which may not be very much favorable to the kidney on long run. And the sodium may be quite needed, but the chloride may be a unnecessary addition most of the time, which can increase the hyperchloremic acidosis and AKI possibility. And the another thing is this is very, very important, because in an intensivist perspective, whenever a child with so much amount of sickness comes, we always depend our management based on fluid resuscitation. Every fluid is a drug, and the fluid has to be very carefully used. Our intended pathway, this is our intended pathway, that fluid infusion improves the mean systemic pressure, improves the cardiac output, improve the MAP and microcirculatory flow, oxygen availability, tissue oxygenation, aerobic metabolism, and organ function improvement. This is our anticipated or expected pathway. But this may be blocked by many blocking agents like capillary leak, vasodilatation, preload and responsive state, microcirculatory dysfunction, hemodilution, tissue edema, lung edema, mitochondrial dysfunction, everything. So we have to be very careful that the fluid may cause intended response, or there are many other modifying agents which may completely paralyze the pathway and cause something like an adverse event. So whenever we give fluid, we have to be very careful to ask two questions. Was the fluid infusion effective? Did the fluid infusion exert adverse effects? I'm not going into the complete table, but these two are very, very important questions, recently recognized, like always we recognize this, and it has been clearly elucidated in recent reviews. And so if you see this, you need not go into the each and every component of it. And for an intensivist, when he is giving a fluid infusion, he wants tissue oxygenation improvement. This is the line we want. Tissue oxygenation, yes, there is an improvement. But you see, there are so many other pathways which can happen. From this to this, there are so many other things can happen. So we want this improvement along with no lung edema, no hemodilution significantly, no RV dysfunction, no intra-abdominal pressure increase. So this is an excellent combo we were aiming at, but there are many, many modifying agents which can modify this. So in this, we understood that in this case summary, we understood how we have to optimize the circulatory volume, how we have to be very careful about the preload optimization. Giving fluid back and forth may not be the right stuff to do. Optimize the mean arterial pressure to restore the renal perfusion. Start vasoactives whenever needed. Don't wait only for the fluid effect and delay the vasoactive. Any prolonged shock is problematic because it has a negative influence on the outcome. Optimize the oxygen carrying capacity, monitor and maintain electrolyte homeostasis, and context-specific interventions. So these things have been highlighted in the current case management summary. So this is the last slide. And so all these principles are like what we have described, like 8 principles. These are all the principles of conservative or preventive approach management of AKI. So if all this fails, or if you think that you are anticipating that these may fail, then that may be a candidate for RRT. But we may not be able to say simplistic values or cutoffs to decide about renal replacement therapy. And mostly in ICU, at least in ICU, it is based on trajectories. So fluid balance trajectory, acid base and electrolyte trajectory, and lung involvement and ventilation trajectory, whether it is increasing ventilatory requirement or not, new organ dysfunction trajectory, along with the pre-illness renal reserve and heart status or hemodynamic reserve. So the disease progression or improvement trajectory, this is what you have to decide. So the disease is progressively worsening. You are anticipating that next 48 hours will be like a more injurious to multiple organs or to AKI, then we may decide about RRT. So this is like this is what eventually happens in ICU. Thank you very much for patient listening. And Thank you, Dr. Kalaivan.
Thank you, sir. Thank you for taking us to the clinically oriented discussion of AKI. Thank you very much. The next talk is by Dr. Anil Vasudevan. He's going to talk on renal replacement therapy, the principles in it. And Dr. Anil Vasudevan is a professor and head Department of Pediatric Nephrology at prestigious Institute St. John's Medical College Hospital. And his area of interest is genetic renal disease, molecular basis of nephrotic syndrome, acute kidney injury, and low-cost devices. He's a secretary of Indian Society of Pediatric Nephrology, member of committee the competence-based syllabus in pediatric nephrology, Medical Council of India, and he is a member of PhD committee, JIPMER, RGUGHS, and St. John's National Academy of Health Sciences. He's a member of editorial Journal of Pediatric Nephrology, webmaster, Asian Society of Pediatric Nephrology. Over to Dr. Anil Vasudevan.
Thank you, Kalai, once again for your kind invite. And it was an excellent talk by Sashi, which laid the foundation of what all about AKI in an acute care setting. So over the next 15, 20 minutes, I'll be talking about one of the important cornerstone of management of AKI, and that is renal replacement therapy, or what now is known as kidney replacement therapy. So, so now we are all aware that AKI is a global concern with a high incidence among patients with acute care setting. Is the slide visible?
Yeah, sir, it is visible.
Yeah, okay. So, while fortunately most of the patients with acute kidney injury in an ICU we can manage with conservative measures, up to a quarter of these children need dialysis, and this proportion is increasing every year based on the data from various population cohort. And there is a wide variability in practice patterns and outcome, with nearly mortality being close to 50%, anywhere between 30 to 50% of those children who require dialysis in the ICU. A unique problem or a challenge that we in a country like ours or an emerging economy faces is the resource crunch, the reduced availability of trained staff and equipment, the socioeconomic aspects, and administrative and governmental barriers, which all affect our patient selection, the choice of modality, and management of renal replacement therapy in general. So let's come to a case of a 5-year-old child, something Sashi had described, who was admitted with a community-acquired pneumonia and shock, intubated, sick, did not respond to the fluids, is on 3 inotropes, and is looking edematous with a poor urine output, and the cumulative fluid balance is around 2 liters. And the creatinine after 48 to 72 hours has risen from 0.9 to 1.2 milligrams. So the questions I would like to ask at this point are, is dialysis indicated in this child? If so, should we start it immediately, or can we wait? What is our goal? What are we trying to achieve by doing dialysis in this child? What kind of a dialysis should I provide? And what should be my prescription? When do I stop dialysis in this child? If the creatinine comes back to normal, or the blood pressures improve, when do I stop? So as you can see, there are many facets to providing dialysis in a child with AKI. Although there are many evidence-based guidelines and recommendations, there is a substantial uncertainty in many of the fundamental aspects of KRT, of providing renal replacement therapy. And I'm going to briefly touch upon these because we have just 20 minutes. I'll be very brief, not going into too much of details of these aspects. So it is recommended that we should begin dialysis emergently when life-threatening changes in fluid, electrolyte, and acid balance happen and that are unresponsive to medical therapy, or when the metabolic and fluid demands exceeds total kidney capacity. So there are no magic numbers to each of these parameters that I have listed. In fact, there is insufficient data to support quantifiable values for acidosis, hyperkalemia, and other metabolic disturbances. But there is sufficient data to provide guidelines on fluid overload, which I'll come to the next slide. But an important aspect that we need to remember while deciding on dialysis is that we need to consider the broader clinical context, not just the AKI. And also our decision will not be based on a single value of a high creatinine or urea, but what, as Sasi said, a trajectory of what was happening before and what we expect to happen over the next hours or days. And ultimately, by doing dialysis, we hope to optimize the fluid status, maintain the metabolic, nutritional, electrolyte balance until the kidney recovers. And by taking over the job of the kidney, we hope that ultimately it helps in renal recovery. So as I said, there is one evidence that we have for starting dialysis is the cumulative fluid overload, which is basically a balance between what you're given and what has come out in urine and through other like NG tube or drains, and by the patient weight. So as you can see here, there is a incremental increase in mortality as the cumulative fluid overload increases at the time of initiation of dialysis. And this was initially brought out from the CRRT registry by Goldstein et al. And subsequently, various studies, mostly single center, except one multicentric study, has consistently shown that fluid overload more than 10% or 20% is associated with increased odds of death. So you have a clear indication of when to initiate dialysis in these situations. So while it is well accepted that dialysis should be initiated emergently in patients with life-threatening electrolyte and acid-base conditions, we also need to consider other factors. So a sick child in the ICU will have a bleeding tendency, may have multiple IV lines, and we compete often for the vascular access, for a poor hemodynamic status, and a cardiac function, maybe on ventilator, may have undergone an abdominal surgery or an organ transplant. So multiple factors, other factors other than AKI needs to be considered, especially the sickness, the prognosis, and the comorbidities. And apart from that, we also need to consider the logistics and cost when we are deciding to dialyze a child with AKI. And many a times we are faced with an ethical dilemma, especially in a child who has come with acute kidney injury but has a poor underlying, or a poor prognostic underlying condition like a relapse of malignancy which cannot be treated, or a myopathy child in the terminal stages. Hence, considering the sickness and extrarenal involvement in these children, it is very important to have a team approach while considering dialysis in children with AKI in the ICU. And one of the most controversial aspect of providing dialysis in AKI, and which is always a kind of a tug of war between the intensivist and the nephrologist sometimes, is the appropriate circumstance of initiating CRRT. I mean, the rationale is that why do we wait till we reach a life-threatening situation? Why can't we intervene a little earlier than what we consider as an emergent situation? But however, I have some issues with the terminology that we use as early and late and delayed, especially in our setting where we hardly know when the AKI has developed. We do not many a times know what are the key factors which resulted in AKI in these children because they reach late to the hospital. So this timing definition is very confusing, and especially when we say late, delayed, it seems like we have delayed what was actually to be done earlier. So what I'm going to show you now is a summary of various randomized controlled trials that has been done to answer this question, whether the timing is a key factor in deciding the outcome of these patients. All these studies are in adult. There has been one pediatric study until date. As you can see here, the early, when we say early, it means initiating dialysis within 6 to 12 hours of dialysis. And as not surprisingly, most of those in the early group received dialysis, whereas up to 50% in some of the studies in the late group did not receive dialysis. While the mortality, which could vary between 30-day to 90-day mortality, 60-day to 90-day mortality, was not different in most of the studies, except in Elaine study where there was a lower mortality in those who underwent early dialysis. We need to remember a heterogeneity in the population that was studied in these 4 RCTs, with Elaine trial predominantly recruiting surgical patients. So these RCTs show us that we still don't have a clear answer whether starting dialysis early is going to make a difference in the outcome of the patient. So, and this is brought out by the patient data meta-analysis, wherein all the 9 studies were included and equal proportion of patients were in the delayed and the early group. And we see that up to close to nearly half of those in the delayed group did not receive RRT. And we can see that the mortality rate is similar, and also that adverse effects, adverse events between the early and the delayed group was not very different. So in summary, while initiating RRT early enough will help us in avoiding early treatment of fluid overload and other metabolic disturbances, immunomodulation, avoiding excessive use of diuretics, and resting the stressed kidney. We also need to remember that we could avoid complication-associated catheter insertion and anticoagulation, repeated episodes of hypertension, especially when you're using intermittent hemodialysis, avoiding excessive clearance when we're using the continuous modes, which may lead to suboptimal antibiotic levels when we are considering a late initiation of renal replacement therapy. So now, once we decide on dialysis, there are various modalities that are available. And in parallel to the changes in the AKI epidemiology, there has been dramatic changes in our approaches to RRT, with a great number of modalities being currently available for children. And also, apart from the various modalities like the and of these, the most commonly that was used before were the PD and intermittent HD, and then came the CRRT, and then the hybrid technologies. Apart from these expansion of the armamentarium, we also had simultaneous development in the technology field that made dialysis safer. So what was once considered an extraordinary measure, the ability to provide RRT, even in the setting of marked hemodynamic instability in severe shock, has now become a routine thanks to these various technologies where we can even dialyze a neonatal using an extracorporeal technology. So unfortunately, the availability of this modality is not uniform across the world, mainly because of the technological complexity and the cost that needs And as you can see here from the survey, while peritoneal dialysis is available in most of in all the centers, whether it's in the developing or the developed country, CRRT and the sustained low efficiency dialysis is available only in a small proportion of the centers. So clearly, while we talk about modality of dialysis, we need to understand, we need to be cognizant of the context and the region that we talk about. So when we compare these modalities, all dialysis modalities provide particular benefits in general, and they also have their own limitations. PD for long, I mean, it's a busy slide, but I'm trying to just highlight key points. PD has long been preferred and utilized as a form of continuous therapy in setting of AKI in smaller and younger children. And it clearly needs a very minimal infrastructure and equipments, and could be run even by, and you don't need any specialized training. While the extracorporeal technologies that include hemodialysis, lead, and CRRT are more complex, needs additional training. It's very important. What we need is a good vascular access. But of course, it comes with a good benefit of able to control the ultrafiltration and solute clearances. We're able to dose more accurately, especially with CRRT, but cost is often a limiting factor. And SLED is somewhat a hybrid, something very similar to CRRT, which can be done probably at 1/5 of the cost of CRRT. So as I said, one of the lifelines and a critical determinant of good dialysis will be an access. So in peritoneal dialysis, you could use a stiff catheter or a soft catheter. Using a soft catheter allows us to do a continuous form of dialysis, whereas with stiff, we are limiting our dialysis duration to around 72 hours. And in coming to the extracorporeal methods of dialysis, we need to have a good vascular access, and we have and choosing the right catheter becomes very important. And this table highlights the various catheters that should be used based on the weight of the child. And as I said, it is very important to pay attention to the size of the catheter that we are going to use while we are considering CRRT, SLED, or hemodialysis. The site of insertion could be femoral or IJV. Also, data has shown that the filter life, especially in CRRT, is much more better when we use an IJV catheter. However, the mechanical dysfunction and other complications are comparable. And whenever we fall into a problem with the existing catheter, it has been shown that it is better to use a new site rather than do a guide wire exchange, because that has more of chances of a catheter dysfunction. I'm not going into too much details about the prescription, which is again another important component while we are advising dialysis. In peritoneal dialysis, we need to ensure an appropriate volume, but many a times, because the child is ventilated and it could compromise the ventilation because of expansion of the abdominal cavity, we may not be able to reach the optimal volume. The exchange time varies depending upon the indication, especially when it is a life-threatening hyperkalemia or pulmonary edema. You need to decrease the duration of your exchange time, while in other condition where it is not so emergent, you could consider a longer dwell time. Similarly, the duration of therapy in extracorporeal varies with the modality that we use. Generally, it is up to a day in SLED. It is much shorter hemodialysis, while you can continue CRRT beyond 3 days but if it's managed well. The prescription, it's very important to get the blood flow rate right, but many a times it's not possible because of the hemodynamic status. The dialysis rate is much lower in PRT and SLED as compared to hemodialysis. And depending on the modality you use in CRRT, whether it's in hemodiafiltration or a hemodialysis or hemofiltration, the dialysis rate can vary. PRRT and CRRT allows us to do what is called a hemodiafiltration or hemofiltration. So here also, one of the drawbacks in SLED and some of the machine is that we cannot titrate the replacement fluid rate. So it is not compatible, generally advisable to use this SLED modality in weights less than 20 kgs, and which is an advantage for CRRT where you can do it right from neonatal age onwards. A second dimension of the prescription is the volume management. So the net ultrafiltration that we are going to set can be adjusted independently of the solute clearance and is based on the clinical situation and need. Generally, we start at 0.2 to 0.5 ml per kg per minute or 1 to 2 ml per kg per hour, and we titrate this based on the what the needs of the patients are in the next subsequent hours or days. So while we have spoken about the prescription, the vascular access, and talked about a few characteristics of these modalities, one way of comparing this modality, objective way of comparing it is by quantifying the renal replacement delivery. And we often use many jargons to address this, like efficiency, wherein it's related to the amount of solute that we remove. And when you multiply it by the duration of dialysis, it becomes intensity. For example, hemodialysis is a good efficiency modality, but when you combine the intensity, whereas CRRT is actually a low efficiency, but can be given for a longer duration of time. So when we combine these two, it gives the efficiency and the intensity, which gives us efficacy. CRRT turns out to be more efficacious as compared to hemodialysis, especially in a hemodynamically unstable child. So, as I said, the objective way is to look at how good the delivery of the dialysis is, and we are looking at solute clearance, which could be broadly of two types: the diffusive, and the convective. And the dialytic therapy, like peritoneal dialysis, relies predominantly on diffuse solute clearance. And this limitation is that it is generally restricted to low molecular weight like urea and other substances, whereas solute removal during a high flux hemodialysis or a hemodiafiltration or hemofiltration occurs by convection, which helps in clearance of middle molecules and larger molecules. So in diafiltration or hemofiltration, what you're doing is you're setting a high rate of ultrafiltration across the semi-permeable hemofilter membrane by a hydrostatic gradient. And here the solid transport occurs by convection. And what happens in hemodialysis filtration is that these solutes are entrained in the bulk flow of water across the membrane, a process called a solute drag. So as you can see, in CRRT, when you combine hemodialysis filtration with a long duration, you are invariably going to achieve a high solute clearance. But whether HDF is superior to HF or to HT is not very clear. It is more determined by a provided preference. As you can see from a multicentric US study, that various centers used various method of dialysis when they were using CRRT. But most commonly, what was used was CVVHD or hemodial filtration. And other important component of the prescription, which I didn't talk earlier, was the choice of dialyzers when we're talking of extracorporeal therapy. And we generally use a biocompatible membranes for both HD and CRRT. And according to the dimension of the pores, the membranes can be divided into a high flux and a low flux membranes. So generally, the dialyzer is chosen based on the body surface area, which should be at least 2/3 or equal to the body surface area of the child. And as you can see here, the dialyzer we can choose based on a multiple body surface area. And we also need to remember the priming volume, because we need to ensure that the extracorporeal volume does not exceed more than 10% of the total blood volume. And similarly, in CRRT, the choices is much limited as opposed to HT or SLED. As you can see, there are only 3 common surface area available. So anyone less than 10 kg, we use a 0.2, between 10 and 20, or 8 and 20 kg. So up to 30 kg, we use 0.6, or more than 30 kg, we use a dialyzer with a surface area of 1. Another aspect that is now being available is the new generation high cutoff membranes. The cutoff represents the molecular weight of the smallest solute. So generally, a conventional traditional membrane removes substances in the range of 20 to 50 kilodalton, while the higher cutoff membrane have the ability to remove larger molecules, like, for example, cytokines. And this brings us to the 2 important aspects of CRRT, which is considered as a favorite modality among the intensivists, because there is no doubt that sepsis-induced AKI is one of the major causes of AKI in the ICU, and that it is very attractive that the removal of endotoxins and plasma cytokines by an extracorporeal purification method may help in control of sepsis, because sepsis is basically an imbalance or a dysregulation of the immune system, where there is imbalance of the anti-inflammatory and pro-inflammatory response. And what we are trying to do is to restore the balance using an extracorporeal form of therapy. While it is shown that in CRRT there is an increased cytokine clearance, however, the data do not support, it has not changed the outcome in terms of renal recovery or patient outcome. And as of now, based on the current data, we should consider the use of CRRT as an adjunctive therapy in sepsis, not beyond, and we cannot consider it as an adjunctive therapy in sepsis beyond its role for renal support. And considering this limitation, there are newer ways of dialyzing a patient with sepsis, and that includes using the principle of adsorption. You have cytosorb, which I'm sure Dr. Akash Deep will be speaking about. And also in CRRT, you have a modification of the existing filters, where they have coated the AN69 filters with polyethylenamine and unfractionated heparin. That results in an increased absorption of endotoxin and cytokines. But the experience in pediatric is extremely, and also in adult, is extremely limited with this technology. Another aspect of CRRT is that in CRRT we could measure the quantity of blood purification that we are achieving. When we speak of dose of CRRT, basically the effluent flow rate, that is your total ultrafiltrate rate and plus the dialysis rate. There has been many studies to determine what should be the dose of CRRT, and various studies have looked at 25 ml per kg per hour to 35 ml per kg per hour. But the current consensus is that that 20 to 25 ml per kg per hour of dose would suffice in most patients. As you can see here, there's a dose limiting effect. So increasing the dose beyond this 25 or 30 ml per kg per hour does not provide additional benefit. In children, we do not index it to body weight, we index it to body surface area, but we should remember that the indexing it to body surface area results in a 3 times higher dose when we equate it to 2 milligram up to ml per kg body weight. So a 2 liter per 1.73 meter square equals 80 ml per kg in a neonate. So as you can see, there's a significant difference in the way we prescribe the dose of CRRT in children as opposed to adult. So while peritoneal dialysis, one advantage is that we don't need to use anticoagulation. It's not so with extracorporeal therapy. Many times these children are bleeding, and hence we are forced to avoid anticoagulations. And we use saline boluses. But this is not an option if you are considering CRRT. Sorry. So the most common and popular form of anticoagulation is the systemic anticoagulation using heparin, where we use 10 to 20 kg for not always as a bolus, and then followed by a continuous infusion, and this is monitored by using ACT or APTT. But invariably, the systemic anticoagulation brings the risk of increased bleeding, heparin resistance, and what is also called as heparin-induced and thrombocytopenia. As an alternative to unfractionated heparin, we could consider low molecular weight heparin, but it is more costly, has a longer T-half, especially in renal failure, and they need special assay to monitor. So in order to overcome the adverse effect of systemic anticoagulation, regional anticoagulation has been used in CRRT using a citrate-based approach. But here, apart from the cost, we need to monitor ionized calcium regularly and throughout the dialysis period. Hence, it becomes a little resource intensive. And common side effects are, although the bleeding tendency is decreased, are alkalosis and citrate lock-in in children with liver failure. And more recently, Dr. Akash Deep's group has described the use of prostacyclins, which has a very short half-life. The dose is 2 to 8 nanogram per kg per minute, and which could be used with or without heparin. And what is the most side effect that has been observed with the use of this is hypotension, and we'll be probably hearing more about this when Dr. Akash Deep has his talk. So while we have described various characteristics, does it impact on the outcome? Is PD better than HD or HD better than PD? So while no RCT exists, the retrospective studies in children have shown not much of difference between the various modality, but however, we need to see that the sicker patients receive more complex like CRRT or PD, or a lesser complex continuous modality like PD, while more stable patients receive intermittent form of therapy. So there is a confoundment of the severity of illness when we look at outcome of patients, but in general, there is no difference when we compare one against the other, except in the study by Munchman et al. But as I said, it was influenced by the severity of the illness. Similarly, a systematic review in adults have shown that the RRT modality does not necessarily impact on the renal recovery, although there is some indication that when you use CRRT, there is a lesser risk of dialysis dependence, but this does not hold when we consider the RCT. So in summary, the modality that we are going to use does not necessarily influence the outcome or renal recovery based on these studies. So how do we choose a modality? I mean, I should say that each modality is unique, so we should not be comparing these modalities as like it will be almost similar to comparing apple and oranges. So apart from the characteristics of the modality, we need to consider other factors, including the clinical status of the patients, and also the physician preferences, the organizational characteristics, like what is available, the cost of therapy, and whether we can provide this particular dialysis safely, and also on the dialytic indications, which I'll come to later. So all these factors needs to be considered before we decide on what modality should the child be on. When we did a survey of pediatric nephrologists as to what factors influence their choice of the choice of modality in their clinical practice, we asked them to rank them from definitely important to important, and we found that patient size, hemodynamic status, the duration of AKI, severity of hyperkalemia, and the fluid balance all are important factors, and so does socioeconomic status of the child's family, which influences the choice of modality. So this is data from our ICU of PD. This is on 113 children. As you can see, most of them very, very young. So that is a preferred choice, I think, universally, especially in those less than 10 kgs. And nearly 50% of them survived, those who received peritoneal dialysis. We were able to achieve a good clearance. And also the most common complication we observed was hypokalemia and hyperglycemia, and very little amount of infections. Similarly, we also looked at our SLED data, where 33 of our children underwent SLED with a cumulative of 103 sessions. And the lowest weight that we were able to perform SLED was 8 kg. And as you can see here, that most of the children tolerated the SLED very well, although they were very sick and all of them were on multiple inotrope. The complications that we faced were hypotension, but only 10% of them needed termination of the particular session of dialysis, bleeding, and filter clot. This should have been 26%, not 46. 1/4 of them did have filter clot because we couldn't use heparin in view of their coagulopathy. So all this some data shows us that, and the character shows that we cannot adopt a one-size-fits-all approach. We need to ask 4 questions when we are deciding on the modality of dialysis, whether it's solute or fluid removal, how rapidly we need to remove, is the patient hemodynamically stable, and what are the resources and expertise available at our disposal. So we should see these modalities as complementary rather than competitive. So if you have a child who's severely sick or an acute brain injury, we need a continuous form of dialysis, and their hemodynamic status improves, we can switch to the other modalities. Similarly, if one modality does not meet our goals, we could switch to the other modality, and probably mobilization of the patient out of the ICU into the ward or home easier, especially if the AKI is prolonged, if we have if we opt for peritoneal dialysis with soft catheter. So while we have talked about choosing a modality and initiating dialysis, we have to remember that the course of a critical ill child is like an approaching storm, which can vary in intensity, the speed, the direction. So does in a critically ill child, the metabolic demands and the fluid demands vary. So we need to monitor patient-related parameters like the hemodynamic volume status. We need to monitor laboratory parameters, not only to assess efficacy, but also to pick up the adverse effects, and including of anticoagulation early. And it is a very dynamic process, the prescription of RRT. We need to reassess the delivered dose against the prescribed dose and need to titrate this based on the condition of the child. And very important, if the facility is available, we need to monitor the antibiotic levels, because as I said, especially with CRRT and SLED, there can be increased clearance and the use of higher cutoff membranes. There's increased clearance of these antibiotics. So when we start, when should we stop? Here again, we do not have clear consensus. There are no clinical guidelines to provide specific recommendations of when and how to stop RRT in recurring patients. There is even greater paucity of data on when to stop KRT as opposed to the timing where you have a lot of RCTs. The data comes from mostly from observational studies, and there are a lot of variables that have been looked for to decide on when to stop dialysis. But it seems like urine output is the most robust and the most described predictor of discontinuation of renal replacement therapy. So in conclusion, renal or kidney replacement therapy is one of the cornerstone in the management of AKI, and children with serious and potentially life-threatening complications need to undergo metabolic or dyselectrolytic, need to undergo dialysis. And the choice of modality, the options have evolved and expanded throughout the years, but still there are uncertainty in many aspects of the RRT management, which have briefly reviewed. And we should view the different modalities as a continuum rather than as discrete, and we should avoid a one-size-fits-all approach. We should use a modality that is available, affordable, and which, very importantly, we can provide very safely. And so PD becomes a choice in a resource-limited setting and small babies, and SLED is an effective alternative to CRRT based on the solute clearance and also the available data. And finally, clinicians managing these patients are the best people to decide when to initiate RRT and what modality to use. Thank you for your patient hearing.
Thank you, sir, for giving us a brief outline on various modes of renal replacement therapy. Thank you, Anil, sir. The next speaker is Dr. Akash Deep, who's going to talk on COVID during RRT during COVID. Dr. Akash Deep. Dr. Deep is the Director of Pediatric Intensive Care Unit at King's Institute Hospital, London, and he's a reader in Pediatric Intensive Care at King's College, London. Dr. Deep is a chair of Critical Care Nephrology section of European Society of Pediatrics and Neonatal Intensive Care Society. He has organized and taught on several national and international forums. He is a chair for the Scientific and Educational Committee of Pediatric Intensive Care Society of UK. Dr. Deep is a key medical advisor for UK Sepsis Trust Executive Committee, and he represents the NHS England in the core panel group of standardized pathway for care of acutely unwell children in emergency department. Dr. Deep has organized many national and international congresses on CRRT and hosted the prestigious 8th International Conference on CRRT in London and the 9th International Conference on CRRT in Orlando, USA. He was the organizing chairperson for 2019 UK's National Pediatric Intensive Care Congress in collaboration with American's Pediatric Cardiac Intensive Care Society. He's organizing chairman for the first International Conference of Pediatric Critical Care Nephrology in Children being organized in London. And he has authored several research articles in leading peer-reviewed journals and has contributed a lot of chapters. And he's a chief editor for first ever book published by Springers on critical care nephrology and renal replacement therapy in children. And he was awarded the National Bronze Award in 2016 for his exemplary contribution in NHS. His special interest includes acute liver failure, acute kidney injury, CRRT, hemodynamics and septic shock, sepsis, awareness campaign, and liver assist devices in liver failure. Over to Akash Deep.
Great. Thank you so much, Dr. Ganesan, for the invite. I'm humbled, and I think both Dr. Anil, Vasudevan, and Sasidaran have laid a very, very solid background on which I can actually skip through a few of my slides because there will be an overlap on what I'm going to speak. So this pandemic, the COVID pandemic, started in China and then very, very rapidly spread throughout the world. And as it was spreading, what we were all worried about was the ventilators. We were worried about how are we going to ventilate such a huge amount of patients with ARDS. But little did we know that these patients who have got ARDS actually will end up developing acute kidney injury as well. And we would end up being in deficit of both the machines and the consumables for renal replacement therapy, whether it was CRRT, whether it was intermittent hemodialysis, or whether it was PD. So what I plan to do in the next 30-40 minutes is to take you through what the approach should be for RRT in the setting of a pandemic. Now, before I do that, unfortunately, a very close friend and a colleague of ours passed away a couple of months back, Dr. Rupesh Vimani from New York. He was with us last year, and I think I would very much want to dedicate this talk to Rupesh, who has always been a great friend of mine. Now, coming to acute kidney injury and what devastating effects it has, we all know it from non-COVID studies. But in COVID studies, what has been demonstrated in children initially was that it's rare and the effect on mortality was not that great. But that was initial stuff. You must have seen that there are lots and lots of webinars, of papers, of pre-edited letters coming out, and every week the literature changes. And now what we are coming to know is that acute kidney injury, especially when it's a multi-system inflammatory disorder, it's getting commoner and commoner. Now, how much does that contribute to mortality? I'm going to show you in the next study. This was a study done in New York. It was about 5,500 adult patients admitted to the hospital, of which 1,400 patients were admitted to the intensive care unit. They all had COVID-19, and 36.6% of them had developed AKI. The peak stages of AKI, as you can see, was a majority were 46.5% for stage 1, and 22.4% stage 2, and 31.1% stage 3. So if you look at severe AKI, which is a combination of stage 2 and stage 3, so you still get a lot of patients who had developed severe AKI, and almost 15% of them require renal replacement therapy. So 15% of the 2,000 is not a small number, so you require a lot of equipment for that. If you look at it, most cases developed AKI either at admission or within the first 24 hours. So again, very, very vital that pre-ICU admission management is very important. A patient comes to a community setting, for example, looks dehydrated. Dehydration could be because of whether they've got diarrhea, vomiting, they've got decreased intake because of the disease process. That needs to be treated. A lot of them are actually functional AKIs. So as I said, a lot of them present peri-admission. And if you look, this is a very interesting slide. You can see that the occurrence of AKI is actually coinciding at the time of intubation. So the median time between when a patient got intubated to starting of dialytic therapy was only 0.3 hours. About 90% of patients who were mechanically ventilated developed AKI versus about 22% of non-ventilated patients. About 97% of patients who were on RRT were also on ventilators. So there seems to be a correlation between respiratory failure and between acute kidney injury requiring dialysis. And this was the conclusion of this study, that very common in hospitalized patients with COVID-19, strongly linked to the occurrence of respiratory failure and development of AKI, conferred a poor diagnosis. And of course, as it is a developing time and we are still trying to understand it, further studies are required to better understand it. Now, what about pediatrics? Are we doing anything in pediatrics? Yes, our colleagues, which we have called a prospective pediatric acute kidney injury research group, we have got 33 participating centers, and we are participating in the pediatric AKI registry and collaborative for SARS-CoV-2, and these are the inclusion criteria. And there are about 350 patients who have been included in the study so far. And when I last spoke to the team, the data was being analyzed. Now, this is something which I think has become the bread and butter of every webinar nowadays, the pediatric inflammatory multisystem syndrome temporarily associated with SARS-CoV-2, called PIMS-TS in the UK, and called a multisystem inflammatory syndrome related with COVID-19, called that MISC, M-I-S-C, called in the United States. So these patients present a couple of weeks after probably they have developed COVID. A lot of them can be COVID PCR negative, but a majority of them are actually antibody positive. And what is characteristic in these patients is the amount of inflammation these patients have. These patients present about 66% in our series, which we published. This is a paper published in Lancet by us about, again, 3-4 weeks back, and about 66% of our patients had diarrhea, vomiting, abdominal pain, to an extent that 2 of them underwent a laparotomy, thinking that probably it's appendicitis. So abdominal symptoms, very common, cough, less common, fever was a universal criteria for these patients. So after seeing what we had, and my interest has always been acute kidney injury, we then approached all the PICUs, the pediatric ICUs in UK, and we collaborated and said, let's look at acute kidney injury in pediatric inflammatory multisystem syndrome, the PIMS-TS, and see what do we find. Is there something striking which we have not seen in AKI of non-COVID patients? And I'm very glad to share that this paper has been accepted for publication in Critical Care Medicine and will be coming out very soon. And what we found was that any stage AKI, if you look at any stage, so 116 patients, first of all, we had from 15 PICUs, any stage AKI developed in 41.4%. It's a huge number. Severe AKI presented in 27.6 patients per percent of the patient, which means 1 in 4, rather more than 1 in 4 patients developed severe AKI. And again, similar to the New York paper, 75% of our patients had AKI at the time of admission or or peri-admission. On univariable analysis, we had lots of things which came as important, including the body mass index, obesity, hyperferritinemia, high CRPs, high PIM3 scores, being on vasoactive medications, and being invasively ventilated. But when we entered all these things into a multivariable logistic regression model, hyperferritinemia was associated with severe AKI as compared to non-severe AKI. It was also seen that more severe the AKI, longer was the PICU stay and longer was the duration of invasive mechanical ventilation. So our conclusion was that severe AKI develops in a quarter of patients, or just over a quarter of patients who were admitted to UK PICUs. Hyperferritinemia was significantly associated with severe AKI, and we had a bad morbidity in the form of increased PICU stay and increased duration of ventilations. This paper should be coming out very soon and shows us that more inflammatory you are, the higher the chance that you will get AKI. And again, from the same paper, you can see that very nicely the eGFR is going up with time, and very nicely the serum creatinine is coming down. There were only 2 or 3 patients who actually had persistent AKI at day 7 of PICU admission. Right, so I think this was what I just wanted to touch upon AKI, because the whole talk is on actually what do we do when a patient, you have done the non-dialectic therapy. When I talk about the non-dialectic therapy, I talk about what exactly Sasidaran has said. Preempt it, prevent it, and manage it. Have a very close eye on fluids, especially in patients who've got PIMS-TS, because they're dehydrated. Remember, they've got high temperature, they're not drinking well, they've got diarrhea and vomiting, so they've got things to be dehydrated. So you need to make sure they are euvolemic, at the same time making sure that you don't overdo it and don't cross the Frank-Starling curve and cause the patient fluid overload. So a very tight balance. Institute your enteral nutrition early, monitor your biochemistry, monitor your urine output, and as the first speaker said, review your medications. There is no replacement for saying the pathology was different, that's why we did not look at the medications. Nephrotoxic medications play an equally important role in the causation of AKI in this pathology as well. So, as I said, there is a pandemic, but there is another pandemic going on, and that pandemic is the pandemic of webinars, the pandemic of guidelines. Each and every society, each and every country, or nationally, internationally, are trying to bring out guidelines. So we have the NICE guidelines, the American Society of Nephrology guidelines, the SCCM for COVID, but unfortunately, there was no mention of management of AKI in COVID-affected children. Initial experience from China said low AKI rates, low CRRT rates, and now things might be different, because with PIMS-TS, you have got myocardial involvement as well. You've got a low cardiac output state, and all these things can affect your perfusion to the kidney. Your cortical and medullary perfusion might be different, and hence your AKI might be different as well. Now, before I go into the nitty-gritties of RRT, the 3 or 4 main principles of RRT, whether it is the PD, the CRRT, lead, whatever you want to talk about, you need to protect yourself and you need to protect your team. There has to be full PPE to be worn. You need to limit exposure to healthcare personnel to absolute minimum. You need to disinfect all the dialysis equipment and meticulously discard all disposable RRT equipment as per the hospital policy. So make sure you adopt the policy, adopt those guidelines where the contact of the healthcare professional with the patient, if not required, is not done. And what you could do is you could use extended tubings. CRRT machines can be placed outside the room with the attendant risks of more frequent clotting, decreased sensitivity of pressure loss, and inadvertent disconnection. So these are the side effects. Yes, you might place a CRRT machine outside, but because there are long tubings, you have all these problems. And but on a positive side, this might reduce the frequent exposure of healthcare personnel and therefore reduce the use of PPE. This approach seems to be less favorable in patients who are less than 16 or 18 years of age, because the primary volume of the machine becomes very large. So very important to understand what you are doing, what are the pros and what are the cons of doing it. The American Society of Nephrology recommends that every institute should continue using what they are doing. If you are using CVVH, which is hemofiltration, continue using CVVH. But I mean, say, it's not a right approach to start training your medical and nursing staff in the middle of a pandemic on a new modality, saying, I actually went and listened to Akash Deep in a webinar, and he said start prostacyclin, and let's start using prostacyclin. That's not the right time, because the whole staff is worried about how to manage such a vast number of patients. How do you manage them? How do they protect themselves? How do they protect their families? And you don't want to burden them more by giving them newer guidelines. So keep doing what you are doing. The principles remain entirely dependent on what the resources are. Where are your resources deficient? Are the resources adequate? And if the resources are limited, in which area are the resources limited? Do you have a shortage of machines or infusion pumps because everything has been diverted to adult services? And I would like to mention here that there's a misconception amongst we pediatricians saying, you know what, it's a surge in adults. We guys are fine. But the problem is that if there's a surge in adults, you will be diverting your staff, your consumables, your machines, everything to the adults, because they need to be managed. And if you have a child now who requires RRT, you will be in a similar condition, you will be in a similar resource crunch as your adult colleague is, because you will be left with nothing. So depends upon your shortage of consumables, shortage of staff, or shortage of machines. Yeah, so what are the options we have? We have CRRT, which includes the hemofiltration, the filtration and dialysis. We have the intermittent renal replacement therapy, which could be the standard intermittent, or the SLED, or we can have peritoneal dialysis. So as Dr. Vasudevan had said, you need to have your prescription very clear in your mind. You need to have a team leader which says to the team members, why are we starting CRRT in this patient? What is the indication? Because if you know the indication, you will be able to stop it as well. And I'll come to that later. Indications might have to be made flexible when you are in the middle of a COVID, where you might say, okay, right, I'm going to start CRRT because the fluid overload is 10%. You might have to think now and say, yes, it is 10%, but the F5 is still 0.3, 0.4. Let's just wait. So your indications might have to be changed. Again, I'm not going to go through the whole of it because it has been covered, but vascular access. There is no replacement for a good sized vascular access. And in the setting of a COVID, you will always, if possible, prefer the right IJV, because when you prone the patients for ARDS, this access can be easily accessed, and this access can be easily, even when the patient is prone, you can actually insert the catheter while the patient is in the prone position. One difference which is there in a COVID versus non-COVID scenario is the anticoagulation. These patients are highly prothrombotic, and their filters clot very easily. We'll come to that a bit later. So you will have to have a very close eye on your filter clotting, because more filter clotting means more changing of the machine, the filters, the circuit, more exposure of your staff to the patient, and very importantly, your consumables will go very, very fast. So you need to know what anticoagulant you're using, what dose, what modality, and how are you going to monitor. And very importantly, what we do not know is what does CRRT do to antivirals, to the remdesivir, to the biologic agents which have been started in these patients, because all the trials which have been started, they say being on CRRT is a contraindication for starting them on these drugs. So if we have not studied, how do we know what CRRT is going to do to that? So when do you initiate? Again, Dr. Vasudevan has very nicely covered same indications, but probably, as I said, a bit more stricter with your initiating criteria, but make sure your patient is actually well filled before you start CRRT. Early versus late has already been spoken about, but you have to take into account here, besides the STAR trials and the Acute trials, what do you have? What resources do you have? And they are going to, believe me, get exhausted very fast if you're in a combined adult pediatric hospital. Everything will be diverted. So we had a hybrid model at King's, which I might come back to later, where we had 25% of our beds for pediatrics in PICU, and the remaining 75% of them were given to adults. But what we were left were only 2 CRRT machines out of the total of 6 which we had. We were left hardly with anything. So if our children, being a liver failure center, had required CRRT, we would have been in trouble. So early versus late depends upon, in COVID, on a lot of these things as well. This is the START trial, which Dr. Vasudevan talked about, accelerated versus the standard. And what they said was, among critically ill patients with AKI, an accelerated renal replacement strategy was not associated with a low risk of death. So this is a non-COVID scenario. Even in non-COVID patients, there was no advantage of starting it early. Again, there can be a debate on the methodology, on what happens if a patient is put on renal replacement for hyperammonemia for acute liver failure. So that's a different story altogether. But early does not help, at least in the START trial. Now, should we use convection? Should we use dialysis? Should we use a combination of the two? Theoretically, convection-based can be helpful because you want to remove the large molecular cytokines, but again, it's non-selective. There is nothing new, as I said before, which should be started, because your nursing staff who are running the shop floor and your junior doctors who are running the shop floor will be completely in chaos, not knowing what to do. So the mantra is, do what your unit is used to doing and is good at it. So no last minute changes, please. And this is what I was talking about. COVID-19 being a hypercoagulable state, you got endothelial cell dysfunction, you got loads and loads of inflammation with floating tumor necrosis factor and interleukins, leading to thromboinflammation and a hypercoagulable state. And what does it do? It leads to arterial thrombosis, it leads to venous thrombosis, and very importantly, it leads to a microvascular thrombosis, and this is responsible for your frequent clotting of your filters. And this is how the filters look like. A human hair is 0.09 millimeters or 90 micrometers. These are even smaller than that. And of course, when you then subject these patients to ultrafiltration, as ultrafiltration is coming down, in addition to small size, you are making it the hematocrit increases, the blood becomes more viscous, and therefore there's a high chance that this patient will clot. There is something else called the clogging. When I talk of clogging, I mean it's a protein cake of the various blood products which develops within the pore size of the filter fiber. And this is different to clotting. When I say clotting, there's a clot which gets formed and it blocks the lumen of the filter. Here, the flow is impaired. Whereas when the clogging takes place, it's the permeability and ultrafiltration are impaired. But ultimately, both affect the downtime. The downtime of treatment gets prolonged, and hence the efficacy gets affected. So how do you prevent it? Appropriate anticoagulation. You reduce the ultrafiltration rate and do things which are circuit and filter related. So why are we worried? As I said, it increased downtimes for treatment. You are increasing your healthcare professionals to attend to alarms and change the filters. There's already strain, or there's an additional strain on already strained resources, i.e. more circuits, more filters needed, and of course there are financial implications as well. What are the non-anticoagulant measures? First, as I said, select a good site with a large bore catheter, making sure you address all the catheter-related problems like the location, the leakage, the bending, the kinking. So all these things are very important, and it's said a well-functioning vascular catheter is the best anticoagulant. Set higher blood flow rates, use pre-dilution, and when you're using a pre-filter, make sure that you use a higher pre-dilution there and keep the filtration fraction lower than 10%. What are the ways anticoagulants available? Starting from unfractionated heparin to low molecular weight heparin to regional citrate to prostacyclin, or a combination of the two. And the routes could be systemic, which could be intravenous or subcutaneously, or it could be regional or a combination of the two. And here I would like to stress that a number of these patients who've got COVID will already be started on a systemic infusion of heparin or subcutaneous low molecular weight heparin because they have got a high propensity of pulmonary thromboembolism or deep vein thrombosis, so they're already on that. So what do you do when these patients are already on that? So as I said, if the patient is not on a systemic heparin infusion, you give a bolus first, 20 units per kilo, and followed by infusion of 20 to 30 units per kilo per hour. This is higher than the usual thing. Usually we use 10 to 20 units per kilo per hour. We aim for an ACT of 180 to 220 seconds. If the ACT is low and lots, you go up on the dose of unfractionated heparin by 10 to 20% each time. Side effects have to be borne in mind, especially bleeding and hepatitis. Now, citrate, we all know, is a regional anticoagulant, and how it works is it actually acts with your calcium, ionized calcium off the blood within the circuit, and as we know that calcium helps in the clotting cascade. So the clotting cascade does not propagate, and hence it works as an anticoagulant. And what is different between COVID and non-COVID is that normally you would make a circuit ionized calcium of 0.35 to 0.5, but here you need to maintain slightly lower ionized calcium of 0.2 to 0.3, and you can use a higher concentration of citrate if you want. Now, you've used, what happens when you're kind of, the filters are still clotting, you can actually combine the two. You can have a combination of regional citrate anticoagulation alongside a systemic unfractionated heparin infusion. So 10 units per kilo per hour of heparin, and the regional citrate should be at the same dose as you use for non-COVID, which is 1.5 times the blood flow rate. The problem with citrate, again, this is all mentioned in literature about metabolic alkalosis, electrolyte disorders, and very importantly, the citrate lock, especially when your liver gets deranged, especially when you've got COVID-19. So you have to be a bit careful with citrate, and you might want to avoid it as well. And prostacyclin, I am a prostacyclin using unit in Kings. All our patients, liver or non-liver, go on to prostacyclin between 2 to 8 nanogram per kilo per minute of a regional. We do not infuse it to the patient. We give it regionally pre-filter, and that has got two effects. One, A, it is antiplatelet, and B, it has got as a heparin-sparing agent, and therefore it reduces the dosage and side effects of heparin if you're using heparin as well. This is our protocol, which is available on pcrrt.com/protocols, and I'm very happy to be contacted directly if you want to know about the protocol. And this is what we do. When filters are clotting frequently, when we know antithrombin might be an issue, we use a 3-way tap here. This is heparin and 10 units per kilo per hour. This is prostacyclin 4 nanograms per kilo per minute, and they are being given simultaneously pre-filter. Remember, both the infusions are going regionally pre-filter to the patient. And of course, if you run short of even the infusion pumps, which can infuse heparin and which can infuse citrate, you have no option but to use subcutaneous low molecular weight heparins. And if the filters are still clotting on low molecular weight heparin, you can start a regional citrate anticoagulation along with it. So various options. And if you want to summarize what the anticoagulation summary is, you know, a lot of your patients will already be on systemic heparin infusions, and you need to initially give a bolus followed by an infusion of heparin, maintain ACT between 180 to 220. While you're using citrate regional anticoagulation, you need to aim for a lower ionized calcium levels of 0.2 to 5 instead of the 0.4. You combine your heparin nitrate, you can use prostacyclin, you can combine your prostacyclin and heparin, you can use low molecular weight heparins, loads and loads of options. Again, these are unprecedented circumstances. This is not something you are planning. This is you are doing it because you are forced to do it. The pathology is such that there is more and more and more of it clotting. You can do nothing about it except to tackle it. And how do you tackle it when the resources are limited? Is whatever you had something in hand, you can do that. Sorry, I need to go on to my next presentation. Oh.
It's just below the last slide, sir. Left-hand side, bottom corner, Meta Webinar 2.
I'm gonna go there now.
Able to find it, sir? Yeah.
Yes, I have been. Thank you.
Yeah.
Yes. So, as I said, what you need to do is to just have a very special consideration that our resources are limited. Are your resources limited in machines, which include the machines and the infusion pumps, or are you deficient in your consumables, which includes your replacement fluid, your dialysis fluid, your anticoagulation? What are you deficient in? So when the replacement fluid is in short supply, what do we do? We use lower exchange rates. We start with 20 mils per kilo per hour, but we've got the machine so it can run for 24 hours. And if the patient is only for fluid overload and is not hypermetabolic. Now, this is the first time we learned that fluids from one company can be used with the CRRT machine from another company. We use Aquarius from Nikiso, we have Aquasol, whereas our adult colleagues use Prismaflex from Baxter. And so we kind of lent our Aquasol to them when their fluids were getting deficient. And in extreme circumstances, we even developed our own replacement fluid by mixing saline and dextrose with various concentrations of potassium, sodium chloride, etc., etc. But the biggest challenge here is, again, you have a number of patients who are on CRRT. So therefore, even the electrolytes might not be available to make your own fluid. So it will depend upon what is deficient, what is not deficient. And this is just a flowchart to show how critically ill children with AKI, what do? You talk about the indications. You prepare stuff, including your vascular access and the machines and the consumables, and then you make your prescription very, very clear depending on what you have and what you don't have. If your machines are not there, you might want to rotate the machines between your patients every 24 hours or when the filter clots, or you can use one machine and treat 3 patients, giving them 8 hours of CRRT. So as I said, these are very, very unprecedented situations, and we need to make sure filters don't clot and you don't increase the downtimes for treatment. So these are the differences between CRRT and intermittent hemodialysis. From the COVID perspective, we have to remember that our staff in PICU is not used to using intermittent hemodialysis. Every PICU does not have the reverse osmosis set up to give intermittent hemodialysis. So even if it's available, the choice would be CRRT because people are more used to giving CRRT. And if the need be, you can use prolonged intermittent renal replacement therapy as well. Peritoneal dialysis. I've become absolutely a big fan. We don't use it acutely in adults or pediatrics, but it changed the way we manage the pandemic at King's College Hospital. So it requires less equipment, less consumables. Staff can be easily trained. It can be used using manual or automatic dialyzer. But in COVID-19 patients, is the automated peritoneal dialyzer with a cycler, which is normally preferred. But as I said, when we started using PD, we realized how easy was it for the staff to be trained, especially in acute PD. Just going back to my previous slide, the normal dose is 10 to 20 mils per kilo or 300 to 600 mils per meter square. But in COVID-19, you can actually go up quite up to 1200 mils per meter square to achieve a better solute clearance. Your dwell times can be increased, but one thing you have to be careful is if you are not being able to drain the fluid from the abdomen, that might further compromise your respiratory failure, because then the intra-abdominal pressure goes up. And in a lot of places, people actually regularly measure the intra-abdominal pressure to decide the dwell time and to decide how much fluid they need to drain. So very, very important that the PD is managed appropriately. Of course, the problems are because you're managing PD in a prone position in a patient with ARDS, so there will be a chance of pericatheter leaks, bending, kinking of catheters. But again, as I said, these are unprecedented situations. You do what you have to do. And this is an editorial just published, I think, about 3 weeks back, effect of adult COVID-19 surge on the provision of kidney replacement therapy in children. And you can see here, based on the resources, okay, what dose do you start? If the resources are limited, are you limited in machines or are you limited in consumables? Is the patient hemodynamically stable or not? Based on that, it's a free, it's open access article. You can freely access it. Then we can talk about total plasma exchange, because you've got a patient who is hypermetabolic, inflammation is there, IL-6 is there, everything is raised, and total plasma exchange can be combined with the total plasma with the CRRT. This was a paper during the H1N1 influenza A pandemic, and you see that in all 3 patients, the severity of illness from day 1 to day 3 has decreased when plasma exchange was carried out. Now, how do you do TPE and CRRT together? Some people interrupt CRRT and start TPE, or some people have 2 vascular accesses, 2 machines, and do it simultaneously, and some people do it this way. You have got a vascular access, you've got the total plasma exchange off here, and then it flows back here on the other side of the lumen. This is called parallel, but if it starts here and comes back before it enters into the CRRT, it's called continuous. It's called in series. So you can have a parallel TPE and CRRT, or you can have in series. Well, unfortunately, in adults, people had to decide, should we offer, should we not offer? But very fortunately, in children, we are not posed with this question of equipment, where to give, where not to give. But if everything is occupied, i.e. your machines are not there, your consumables are not there, the decision to withhold this life-sustaining treatment from a child might be very, very difficult. Similarly, if you're reverse triaging, to withhold RRT from one patient to maximize the opportunity to the other, again, will require a lot of discussion, a lot of ethical support, and therefore these discussions have to be open, transparent, and if your institution has got an ethics committee, it's highly recommended that you actually discuss this with the ethics committee. But fortunately, till now, we have not had to make a decision, should we offer RRT or not, because we don't have the adequate machinery to deliver it. This is again just very quickly showing you what do we do if it's non-COVID, and what do we do in reality when there is COVID. And you can see here that whether it is the initiation, we initiated before the onset of life-threatening complications. Here we need to apply stricter criteria. Fluids from the same company to be used as the machine. Here you can use whatever you want to use. the staff, you are very worried when you start CRRT in a non-COVID scenario. You want a particular staff who is trained, who's got a training in their belt, whereas in a COVID scenario, you actually just need to train them as quickly as you can. So again, this is in the same editorial which I've written. What are the challenges? The challenges are because of the disease. Challenges are because of limited resources. And what we should not forget is there's an increased level of stress at the bedside. Physical stress, emotional stress. People are really, really stressed. And if there's less PPE and less experienced staff, this stress becomes more and more and more. And then, of course, we have to be prepared to change the plans quickly. Today morning, I have got adequate CRRT. By evening, everything is exhausted. What do I do? So I need to change my plan. And of course, in addition to all this, there's an urgent need for rapid education, audit, and research during these busy times. So what do we do in this situation? I think the only mantra I have learned is that you need to collaborate. You need to collaborate with your adult colleagues, with your nephrologist, with your interventional radiologist, and all come together. And as I said, unprecedented times, unprecedented things you're doing, and therefore you need to make sure you select your patients properly, you select your modality properly, and you maintain what is best in the best interest of your patient. What did we do at King's? As I said, this is what happened to us. There were, at one given point in time, we had 64 patients in one day on CRRT. And we were absolutely, there was nothing available. We borrowed machines from each other. We actually even went to the industry and borrowed more machines, but things changed when we started doing PD. And you can see that as we started doing PD, the proportion of patients who required CRRT started to go down. So PD really helped us. This was the first PD, and you can see that the requirement of CRRT is a nice icon. So what did we do? We had a tactical team, an ICU consultant, an ICU matron, and there was a lot of admin support. There was a renal PD team. People were taught, interventional radiologists would come in, put in the VAS scats. So as I said, it was all about collaboration. We collaborate with the hematology team to say what is the best anticoagulation device. And again, very, very important is to give moral support to your staff who have been redeployed. Imagine a pediatric nurse going to an adult ICU COVID ward and managing 2 or 3 patients. It is really nerve-wracking. So you just need to make sure that there's adequate support available. So in summary, what I would want to say is that there is no universal plan. Circumstances change quickly with increasing demands in adult surge. Everything will be in short supply for children as well. And the most important weapons are teamwork, knowledge, education and training, be resilient, be there, and have a positive attitude that yes, we'll get through it. And preparedness and flexibility are essential. Dr. Ganesan, how much time do I have? Or do you think we should stop it here?
So if you have a few more slides, you can run on the slides, sir. Not an issue.
Okay, great. So this is the cytosorb thing, which is the adsorption technique. It's not hemofiltration or it's an adsorption technique. It's a bead-like structures, and they bind the cytokines, the IL-6, the 8s, the TNF-alphas, and this has been shown to work both pre-filter. You can see here, this is your filter of the machine, and this is your cytosorb pre-filter, and here this is the post-filter. Both can, but the problem with the cytosorb is the priming volume. The priming volume is huge, and that is in addition to your CRRT. This was the first experience of cytosorb in a child affected by cytokine release syndrome, and you can nicely see that your IL-6 and your ferritins are nicely coming down, and your X-rays are nicely becoming better from PF ratios which were very low, and the child was in frank AIDS. You can see the X-rays were getting better. Now, could this clinical experience be useful in COVID-19? Yes, because COVID-19 is characterized by a cytokine storm, which is hyperinflammation, fulminant multi-organ failure, and elevation of cytokine levels. So yes, this technique can be used. And as you can see, this is going from mild to severe with ARDS and multi-organ failure. And as it is going up, the levels of your interleukins are going up as well. So therefore, the serum levels of interleukins and interleukin-6 positively correlate with the severity of illness, and hence cytosol can be important here as well. So what do we do on day 1? We change the device every 12 hours, on day 2 at 24 hours, and day 3 again at 24 hours. Thereafter, we monitor the levels. We monitor if there's a clinical response to cytosorb, and if there is cytosorb, you can actually continue for about 7 days. As you can see, changing it at 12 hours here, 24 hours on day 2, 24 hours on day 3, and every 24 hours there. So again, this is a continuous hemoperfusion for at least 72 hours. This is IL-6, and this one is your ferritin. If your IL-6 comes down, if your ferritin comes down, and as I mentioned, having hyperferritinemia in PIMS-TS is a risk factor for developing severe AKI. So you might be able to treat AKI there as well. And as a conclusion for cytosorbent therapy, it's a useful potential therapeutic resource. I'm not saying it's a must. If you have it, and your backs are against the wall, you have a child who's in multi-organ failure, you are not winning, it's probably worth a go if you have it. It's not available in all countries, so we are suggesting to use it in exceptional or on compassionate grounds on a case-by-case basis only. Now, before I end, I need to thank Maris Osterman, who is the Ethicum lead and St. Thomas's consultant from London, Richard Fisher, who is the adult IPU guy at King's, lending his slides, Zachariah Ritchie for lending me their slides. This is the guidelines which we have published from the critical care nephrology section of the European Society of Pediatric Intensive Care, talking about acute kidney injury and especially replacement in children. This is the editorial which I was talking about which will affect the provision of kidney replacement children. And this has just come out the day before yesterday in Pediatric Infectious Disease Journal, looking at that you need to look at the inflammatory phenotype in COVID-19, because if you look at literature, COVID-19, very low risk of AKI, but when you have COVID-19 with the inflammatory phenotype, the incidence of AKI actually goes down. And I just want to make sure that you guys are aware that we have a critical care nephrology section. We are very collaborative. I'm the chair for the section. And if you guys want any collaboration on AKI, on CRRT, we want to compare stuff, we are very, very open to discussion, and we're very, very open to collaboration with that. And this is the book, I think in my introduction, Dr. Ganesan was mentioning, Stuart Goldstein and myself wrote this book. It has got all the resources starting from, the history of AKI to the future of CRRT. It covers everything. And this is the International Conference of Critical Care Nephrology in Children, which was to happen a couple of weeks back, but we had to postpone it because of the COVID. It will definitely happen. We don't want to do it virtual. We want to do it face-to-face because we are very sure, like all of us are, that we will come out of this pandemic and we will do it in 2021. And I hope to see a few of you there. Thank you very much.
Thank you very much, sir. And we have covered all about COVID and RRT. Thanks for enlightening us all about RRT in COVID, which is the need for the heart. Thank you so much, sir. We have few questions from the viewers. I think the first question on, do we still transfuse PRBC with a hemoglobin of 7 gram per deciliter if the child is in isolated AKI and not in cardiac or respiratory failure? I think Dr. Anil sir can take up this question.
Well, I'm not an intensivist to answer it from a perspective of a sick child in an ICU. I think there are cutoffs. Definitely, the more anemic you are, your oxygenation is impaired, and it worsens your organ dysfunction, not only of the kidney. But generally, what we see is the challenge in dialyzing these anemic children. We definitely are better, more comfortable dialyzing a child with a better hemoglobin. Because the cardiac status, the volume status will be, tolerability will be better. And sometimes we use this opportunity to prime the circuit using blood, so that it automatically also works in correcting the anemia.
Deep sir, do you have anything to add on to this question?
I would agree with what Dr. Vasudevan said. I think the main thing when you're talking about transfusion in a patient AKI on CRRT is priming purposes. You need to prime the circuit with blood. Our protocol says, again, I would like to mention here, when I say our protocol, it doesn't mean it's a gold standard. I say it because that suits my patient population and my nursing staff are used to it. We use blood priming in children with hemoglobin less than 10, in patients who are on vasoactive agents. And one of the ways of priming is some people actually transfuse blood to the patient, or some people actually prime the circuit so that there is no loss of blood.
Okay. Okay, so now the next question is on early predictors of hyperchloremia-induced AKI, especially in case of chloride-rich fluid like 3% saline, usage as a neuroprotective measures. I think Dr. Deep can take up this question.
So this is on hyperchloremia-induced AKI. Now, hyperchloremia causes afferent arteriolar vasoconstriction. And that is the mechanism how it causes AKI. And again, in the UK, we are going really away from using hyperchloremia. We have started calling normal saline as abnormal saline, and we are starting to use plasma light, I would say. Now, early predict, I don't think there's any study which is saying that if you have a specific chloride-induced AKI, your predictors will be different from a non these things. You have the standard markers. You're going to look at urine marker, and of course, there's a role of biomarkers which we have not touched, whether there is NGAL or whether there's other urinary biomarkers. The reason I don't talk about them very much is because it's not easily available everywhere. And it's very difficult to interpret. Biomarkers can be used to A, diagnose AKI, B, say how the progress is going to be, and people are also saying that they can even predict which patients with AKI are going to require replacement therapy based on the biomarkers.
Okay, so there is no specific predictor to make out hyperchloremic induced AKI. The predictor is like AKI prediction is universal. There is no specific marker to make out.
Basically, what I am trying to say is that, look, if you've got hyperchloremia as such, and that is the only predisposing factor, then AKI is because of hyperchloremia. But if you've got hypotension, you've got hyperchloremia because you're pushing saline, you are on gentamicin and vancomycin, how do you know what is causing what? Because you have a patient who has got multiple risk factors, so it's very difficult to say, you know what, this AKI is because of hyperchloremia.
Fine. Okay, so thank you. The next question is on dose of CRRT and the minimal weight for initiating CRRT. I think Dr. Deep can take this question.
Right. This is something which is always debated even in our centers. So at King's, we have put 1.7 kilo on CRRT as well. A paper literally has gone in last week where we have, I know people talk about Carpedium, people talk about Ecodex, people talk about Nidus. They are small neonatal machines because the priming volume is low. My question to those, I'm not against these machines at all, but my question is, in any PICU, how many children are put on CRRT in a year? 20, 30, 30 maximum. Of that, you're going to divide them into neonates or less than 10 kilos, which these machines can do, and more than 10 kilos. Of that, you're going to further divide because these machines cannot go up on the ultrafiltration rates. If I have got a newborn with hyperammonemia and acute liver failure, I won't be able to use that machine because I won't be able to increase the ultrafiltration, I won't be able to increase the exchange rate. So my staff will end up using a machine only twice or thrice a year. So where is the training? Where is the governance? So what we have tried to prove in our paper is the safety and efficacy of providing CRRT in children using adult machines safely. So as I said, 1.7 kilos, 1.5 kilos, we have done it. But what we maintain is whether it's 1.7 kilos or 3 kilos, 6.5 French in the right internal jugular. And we always have a blood flow rate of 50 mils per minute. It seems really large for a 2-kilo child. It's 25 mils per kilo, but that's how we have been able to maintain our circuit patency. And all our patients, whether they're bleeding or they're not bleeding, they go on prostacyclin as an anticoagulant. So good anticoagulation, a good sized VASCAT, and keeping an eye on the hemodynamics. If our blood flow is 50 mils per minute, I start at 25 and go up in steps to reach 50 within an hour, so that the hemodynamics are taken care of as well.
Okay, sir. Next question is, how do we calculate GFR for medication adjustment during COVID, during AKI? I think Dr. Anil can take up this question.
Yeah, and it's a challenging and interesting question because often we do not discuss antibiotic dosing in a sick child, and more so with who are undergoing dialysis. And we know the fallacies of using GFR-based corrections as that we use in a CKD patient who are in more of a steady state. But for want of better methods of correcting these antibiotic dosages based on kidney function, we continue to use the Schwartz formula. But the best is to use drug monitoring wherever available, so that you can dose it more appropriately based on the pharmacokinetics that are altered in these settings. So in short, I mean, we continue to use the Schwartz formula and use the category of less than 20, 20 to 50, and more than 50% of change of GFR.
Okay. Dr. Deep, do you have anything to add on that?
I think Dr. Vasudevan is the boss. He's a nephrologist. And, you know, I think he's covered it nicely. What we do is we are in a slightly worse scenario because we deal with liver patients. And these liver patients, creatinine you can't depend on because the muscle mass is decreased, the liver is not working well. So we end up in a slightly different scenario. But what we also follow is the BPNA, the British Pediatric Nephrology Association. They have got, based on the height and the sex of the child, they have got the standard more than 95th centile and less than 50th centile creatinine levels. And we say upper limit of normal, lower limit of normal. We use so we use basically all that to calculate the estimated GFR.
Okay, sir. Next question is on in CRRT paper. It's mentioned that CRRT dose for COVID in children is 50 ml per kg per day. Do you have comment on that? To Dr. Deep?
Right. I think my answer is it will all depend upon the resources you have. You have got adequate resources. You have got machines, you've got consumables, you feel that your child is hyperinflammatory. Yes, start at 50, 60 mils per kilo per hour. I mean, say 2 liters per 1.73 meters square per hour equates to about 30 to 40 mils per kilo per hour, right? So it depends upon the resources. If your resources are there, yes, 50, 60 is fine. If you look at my CRRT protocol at King's, our starting dose is 60 mils per kilo per hour, irrespective. Only in AKI. If we are removing the fluid or just for plain AKI, I would use 40 mils per kilo per hour. But for every other patient, whether it's sepsis, whether it is liver failure, acute or chronic, I would use 60 mils per kilo per hour. I have gone up to 120 mils per kilo per hour when my ammonia was not getting controlled. It will depend on what indication, but on COVID, you have the resource of having a machine, you have the resource of having anticoagulation, you have the resource of having fluids. Yes, 50 mils per kilo per hour is fine. As long as you remember that your higher doses also remove more drugs, more nutrition. So you have to bear that in mind as well.
Okay. What are the complications we face during high-dose CRRT, and what is the cutoff of high-dose CRRT?
I think
you answered the question. Yes. It's 120 ml is the highest cutoff, and so what are the complications we face?
Again, I would mention that 120 is what I have gone up to. I mean, to say it depends upon, there might be people who would say, you know what, actually, this patient is on CRRT for sepsis. My patient requires antibiotics more than CRRT. I am removing a lot of antibiotics. Let me just restrict the dose of CRRT, but let my child, because I'm not on those antibiotics whose levels can be measured. If I'm on piptazobactam, for example, you know, and I can't measure the levels, it's very difficult for me to know how much antibiotic is going into the patient. So the side effects are loss of nutrients, removal of antibiotics, and very importantly, you remove so much of phosphate that you are chasing your tail all the time. It's like hypophosphatemia, hypokalemia, you're taking as very frequently, and especially in COVID, when your consumables are limited and you're using very high dose CRRT, you will get it will become a problem.
Fine. Is there any clear-cut indications for using high-dose CRRT?
High-dose CRRT. I use it, as I said, in liver failure with hyperammonemia.
Okay.
This is my one thing where I always will go up till I get control. If people have got the time and the resource, there's a paper on effect of continuous renal replacement therapy on outcomes in pediatric acute liver failure. It was published 3 years back by us at King's, and we have shown that inability to decrease ammonia in 48 hours was the single most important bad prognostic factor. So if you're not able to remove your ammonia in 48 hours, decrease your ammonia, it means the production is so fast that your machine is not keeping pace with the production. So therefore, in liver failure with hyperammonemia, I use high-dose CRRT. There is a debate on sepsis, whether there's the IVOR trial and other trials which have said probably does not help. And if I have got a patient with septic shock, I would personally use 60 mils per kilo per hour.
Okay. Next question is there any specific nutrition for children who are on CRRT for more than 72 hours?
Does Dr. Vasudevan want to take this? I can't hear you. We can't hear you.
Is there any specific?
I will ask the boss of CRRT to answer this.
Oh my God.
Because frankly, at our center, we have for long been managing patients on PIRT because of the cost issues. We use PD and PIRT as a continuous mode more than CRRT.
So what I would like to specifically mention here is we need to distinguish between enteral nutrition and parenteral nutrition. Right, when you're giving enteral nutrition, you know that you need to go up. There will be loss of amino acids, there'll be loss of selenium, there'll be loss of zinc because they're low molecular, but they all will be removed. So you need to make sure that's supplemented, especially when you are dealing with sepsis, because these are all supposed to be adjuvant therapies for sepsis. So make sure that your caloric intake is high, make sure that you supplement the lost amino acids, your seleniums, your zinc, and of course you're removing your phosphorus and potassium as well. If your potassium is low, hypokalemia, your weaning from the ventilator will become a problem because hypokalemia will lead to decreased tone of the muscles as well. So again, nutrition in CRRT, as you all know, is a separate talk altogether. You can talk for hours and hours on different things, but to cut the long story short, you need more calories, you need more amino acids, you need to supplement everything which is being lost during CRRT.
I think we are all done with all the questions. Thank you so much, sir. Thank you for answering all the questions patiently. No. Thank you so much, sir.
No. Thank you, Dr. Ganesan. Thank you, Dr. Vasudevan. And thank you all who stayed back late night. Thank you. Take care. Bye-bye.
Thank you, sir. Take care, sir. Thank you, sir.